Good morning, and thank you for joining the New England Nursing Home Quality Care Collaborative. My name is Shira Doron with the New England QIN-QIO. This is the 5th webinar from our 9-month educational series, Navigating Infection Control and Antimicrobial Stewardship in Long-Term Care, brought to you in partnership with the Massachusetts Department of Public Health and Tufts Medical Center. Today's webinar is Caring for the Long-Term Patient with Suspected UTI. Before we begin today's program, I have a few housekeeping items to review. This webinar will be recorded, and the presentation will be available within a few business days. During the presentation, all phone lines will be muted. We ask that you please do not put your line on hold. If you have a question at any point throughout the presentation, please enter it in the chat panel to the right of your screen. Please make sure to send your comments to all participants. Sarah Dudley from the QIN-QIO team in Massachusetts will be monitoring and responding to questions and comments in chat. You will also have an opportunity to ask questions over the phone at the end of the session. Lastly, if you find that the presentation is a little cut off, please use the plus or minus icons in the top right of the presentation window to adjust your screen accordingly. Now, to introduce our first speaker, I'm going to turn it over to Melissa Cummings from the Bureau of Infectious Disease and Laboratory Sciences and the Massachusetts Department of Public Health. Melissa?
Thank you, Shira. On behalf of the Massachusetts Department of Public Health, I'd like to welcome everyone to today's webinar and thank you very much for your commitment to improving infection control and antimicrobial stewardship in your facility. I'd like to introduce our speakers today. We have three. Shira Doron is the physician head of the Antimicrobial Stewardship Program at Tufts Medical Center. She has been in that position since 2005. She's an infectious disease physician there and also the associate hospital epidemiologist. We also have Shira Beaulac, who is the physician pharmacist head of the Antimicrobial Stewardship Program at Tufts, as well as the infectious diseases pharmacist for the institution. And third, we have Gabriela Andujar Vazquez, who is a physician in the Division of Infectious Diseases at Tufts and is part of the Antimicrobial Stewardship team there, with a special interest in rapid diagnostics and stewardship in the outpatient setting. With that, I will turn things over to our presenters.
Thank you, Melissa. This is Gabriela, and I'll be starting the webinar. The objectives of this webinar are to understand the difference between colonization and infections as it relates to judicious antibiotic use, recognize the appropriate steps involved in assessing a patient who may have urinary tract infection, become familiar with measures of success related to appropriate treatment of suspected urinary tract infection, and identify resources and tools that can be used for managing patients with suspected infection versus colonization. So we'll start the webinar with a case. We have this 80-year-old long-term care resident with a tracheostomy and has been having a fever and a productive cough. She has an indwelling urinary catheter due to incontinence, but no urinary or other symptoms. A chronic venous stasis ulcer on her lower extremity that is unchanged. And she was pan-cultured, initiated because of the fever. And the urine is sent for UA and culture. Sputum was sent of PharmD aspirate from her tracheostomy, and blood cultures were sent also. There was also like ulcer, so it was swabbed for culture. The chest X-ray is done and it's negative. She has a sputum gram stain that has no colloids and no organisms. Sputum grows 1+ Candida albicans. And the urinalysis has 3 white blood cells. The uroculture is positive for more than 100,000 CFU of E. coli. The organism is resistant to all tested antibiotics, including carbapenems. And the wool culture grows varied. So here we have a typical long-term care patient that's chronically ill with multiple medical problems and probably exposed to a lot of antibiotics in the past and now with multiple sites with resistant organisms. So she gets started on IV colistin for E. coli in the urine, linezolid for the VRE in the wound, and fluconazole for the candida in the sputum. She develops a kidney injury from the colistin, thrombocytopenia from linezolid, and 2 weeks after therapy ends developing diarrhea, which tests positive for C. diff. So this is a case where we're trying to portray the difference between having an infection versus colonization. And this patient, what probably most likely had was a viral URI. She just had a cough and a fever, and we cultured everything and we found stuff. And this was treated and did harm to the patient by causing her to go into renal failure. She had bone marrow suppression from linezolid, and then developed C. diff. So we want to talk a little bit about how to approach this type of patients, because they're complicated, and sometimes it's difficult to know the difference between colonization and actual infection, especially in patients that you know that their threshold may be a little low because of poor reserve from multiple comorbidities. So a lot of people carry bacteria and fungi without evidence of infection, so that's what we mean by colonized. If an infection develops, it is usually from bacteria or fungi that colonize the patient. So yes, if you know that the patient has a history of some sort of prior infection in this site that you think that the patient is infected, it is appropriate to think about what they have had before. And bacteria or fungi that colonize patients can transmit from one patient to another by hands of healthcare workers. So we also have to take into account that patients that may not be infected, but we know are colonized. Also, we need to take into account in terms of infection control, because it's not only actively infected patients, but also colonized patients that we do think about in the infection control part of the long-term care facilities. So she did have she does have pre-eval bugs, right? DRE and carbapenem-resistant E. coli in the urine. So like I was saying, it's difficult with patients that have poor reserve, and if you get it wrong, you think that not giving them antibiotics, they will get worse quickly. But we have to also think about the next infection they actually get. It could end up being resistant to colistin, and because we keep giving her colistin inappropriately. So it's sort of a imbalance between trying to figure out if the patient's acutely infected or not, and trying to treat what clinically seems to be the most likely diagnosis. Patients will have recurrent infections. They will have persistent infections in the long-term care facility. So we do understand that sometimes we have a higher threshold to treat, but I would take into account clinically what would make sense that are making the nail at that point. And in her case, was a respiratory issue, and it seems like it was probably just viral at that point. So we talk about the iceberg effect in antimicrobial stewardship and infection control, and the tip of the iceberg is what the patient's actually infected now, right? And then the bottom is sort of what they're colonized with. And just because the patient is not infected or showing signs of infection does not mean that they carry organisms that could be transferred to other patients. So that comes into the concept of proper hand hygiene and making an infection control precautions, that even though we have treated the acute part and the infection, we want to also take into account that they are colonized with these resistant organisms that need infection control precautions and measures. And most importantly, number one, hand hygiene. But do not magnify your problems by making mountains out of molehills. This is basically what says here. sort of the reverse of the iceberg. We know patients are colonized with all these very drug-resistant organisms, and you know, we can get nervous about not treating when we find them. But if clinically the patient is not having fevers, having chills, night sweats, any change, if they're chronically vented, if not changes in ventilation, ventilatory settings, or secretions, no changes in chest x-ray, the wound is not draining pus, or if the patient is able to, not giving you urinary symptoms, then you would not treat because they're not symptomatic, they're not acutely infected. But if you culture, you will find organisms in the wherever you culture in the long-term care. So we're trying to just make a point of the difference between colonization and acute infection, and make sure that we try to balance what we do once we see the patient. What could have been done differently with this patient? So understanding the difference between colonization infection, no white cells in the urine, so no UTI. She did not have dyspnea, hypoxia, chest x-ray changes, nothing that points toward an actual pneumonia. Candida in the sputum, it's very rarely a true pathogen, and it's most often a colonizer from the oral flora. And almost all patients with traits have positive sputum cultures. If you culture them, then you will find anything, but you also want to take into account if they have white cells in their gram stain and their other clinical picture of dyspnea, hypoxia, chest x-ray changes, vent setting changes. And wounds, superficial wound cultures, are often colonized because this wound is exposed to the environment, and they will have that you will culture bacteria not necessarily means that they're infected, especially if they're not having signs of cellulitis, like inflammation, pus coming out, or changes in the actual wound. In sites that are often mistaken as infected, urine, it's like number one. A lot of patients that have asymptomatic bacteria, they get treated, which we'll talk a little bit about later. And respiratory samples, wounds, GI like C. diff, patients that have had C. diff, we know that they will remain positive in their stool for months after even being treated, which is why we usually recommend not to test, no test for cure, not repeating the stool after treatment, because they will most likely be positive still, even after improving clinically. So we go by clinical improvement. So I'll give the microphone to my colleague, Shira, who will talk a little bit about asymptomatic bacteria and adults.
Yeah, so thank you, Gabriela, for really explaining the difference between colonization and infection. And so for the next little bit, I'm going to go system by system, looking at different sites and how you can evaluate the difference between colonization and infection. So as Gabriela mentioned, asymptomatic bacteriuria, or the presence of bacteria in the urine, is a very commonplace occurrence. And it does not warrant treatment except for very specific circumstances. So pregnant women, who I would imagine that no one on the call today is treating a lot of pregnant women in these long-term care facilities, should get treated for asymptomatic bacteria. And the only other instance in which there is definitive guidance to treat asymptomatic bacteria in the urinary tract is if a patient is about to undergo a urologic procedure, and we know that there's going to be some sort of mucosal bleeding or some sort of interaction between the urethral tract and the blood, because we know that there's bacteria in the urinary tract, and that there's going to be communication between the urinary tract and the bloodstream through that intervention, then that would be the only instance in which we would want to treat simply the presence of bacteria without any symptoms. Now,
We're not just saying this because we don't want you to use antibiotics. We've actually looked at the prevalence of asymptomatic bacteria, and as we mentioned, it's very, very common. It's relatively low frequency in healthy younger adults, but when you look at elderly patients living in the community, we're looking at between 10 and 20% of patients are colonized, and once we start looking at kind of the sicker population, elderly patients in long-term care facilities, up to half of patients, half of your women might be colonized with bacteria. When you start looking at patients who use an indwelling catheter, about a quarter of them may become colonized in the short term, and after 2 weeks, 100% of patients with Foley catheters will get colonized. That does not mean that there is an infection present. Now, the other thing to consider is that a lot of people feel that, by checking the urine, if there's white cells there in addition to bacteria, then that probably means that there is an infection present. However, asymptomatic pyuria, which means white blood cells in the urine, is very, very commonly accompanies asymptomatic bacteria. In up to 70% of diabetic women and 90% of elderly institutionalized patients and 90% of hemodialysis patients are going to have asymptomatic pyuria along with their asymptomatic bacteriuria. And again, in the 100% of patients who have a catheter in for more than 2 weeks, 50 to 100% of them are also going to have white cells in their urine in addition to that bacteria. So although white blood cells are helpful for determining if there is no infection, just because there's white cells there or just because there's bacteria there does not necessarily mean that there is an infection. When it's been investigated if there's any benefit to treating these patients, this study looked at women with diabetes who had asymptomatic bacteriuria and gave them an antibiotic course for eradicating the bacteria in their urine and to see if maybe that would prevent symptomatic urinary tract infections in the future. And looking several years out, there was essentially no difference between patients who got antibiotic treatment and those who did and who did not. And aside from that, there was adverse effects in the patients who did get antibiotics. So they're more likely to have negative consequences with no tangible positive consequences. And that's why we strongly recommend against treating asymptomatic bacteriuria. Now, a lot of callers on this webinar have discussed in the past the use of the McGear's criteria for diagnosing urinary tract infection. We'd like to highlight the fact that the McGear criteria is really developed for surveillance and epidemiologic perspective. When you're thinking about clinical diagnosis, there are Infectious Disease Society of America guidelines, and furthermore, the Loeb criteria, which is a little bit more tailored to the long-term care facility population, as a diagnostic criteria for actually deciding who needs antibiotic therapy for a urinary tract infection. So here a flow diagram of the Loeb criteria. Please note that it starts with, does the patient have a fever? If the patient does have a fever and has other signs and symptoms outside of a non-urinary tract infection, so respiratory symptoms, GI symptoms, skin and soft tissue symptoms, in that case, it's unlikely that the fever is going to be diagnosed, be the cause of from a urinary tract infection. Urinary tract infections are really considered a diagnosis of exclusion after you've looked through all the other symptoms and systems and not found anything. If the patient does have a fever and does not have a lot of other symptoms for other types of infections, then you really need to drill down and see if the patient has dysuria, urinary catheter, other urinary tract symptoms. In that case, it would be worth getting a urine culture. We recognize that a lot of elderly patients have a hard time mounting a fever, even in the setting of an infection, and we acknowledge that. So there's even a branch of this that says that if the patient does not have a fever, we then kind of drill down for symptoms based on whether or not they have a urinary catheter. We have a little bit of a higher threshold for wanting to send a urine culture in patients who have a catheter because, as I mentioned previously, a lot of those patients have bacteria in the urine. They really need to have a significant symptom to warrant having urine testing, something like new costovertebral angle tenderness or rigors or new onset of delirium. And just a little bit of altered mental status, or just seeming a little off doesn't really constitute being warranting sending a urine culture. And lastly, if the patient doesn't have a catheter and doesn't have a fever, but does have new onset urinary symptoms, then that does warrant sending a urine culture. Once you have those urine culture results, if they're negative, stop antibiotics. Even if you have extra antibiotics sitting around, that's perfectly fine. They're better off sitting in the bottle versus in the patient's body. If the urine culture is positive, the low criteria recommend to go back and think about the patient and say, if they did start antibiotics, are they the right ones? If they started antibiotics, reevaluate whether or not those appropriate symptoms were there to even send the culture, and also try to narrow to the narrowest antibiotic if possible. So these guidelines will be available via email afterwards. In thinking about colonization versus infection, we have to really think about what is the role of these changes in mental status, because there are a lot of patients that just have cognitive impairment, and we know that patients who have cognitive impairment are more likely to have asymptomatic bacteria. They're also more vulnerable to have any sort of changes in their mental status if they have any other new problem. So if they're more likely to have a change in mental status and more likely to have a positive urine culture, it's especially important in that population to really drill down and assess whether the source of that cognitive change or clinical decline is because of a urinary tract infection, another infection, or something else entirely. So we proposed this acronym for delirium. So when someone has a change in mental status, there's a lot of things to evaluate besides just urinary tract infection. So D could be for drugs, if there's any new drug discontinuation of drugs or changes in drugs that could affect the mental status, really focusing on those on the Beers list. If patients have dementia, specifically Lewy body dementia, but really any, they're going to have predictable waxes and wanes in their mental status. So an acute change in their attention or ability to focus may not necessarily be an infection, but just a predictable decline due to their comorbidity. And lastly, the third D could be discomfort. So if a patient is in pain, that can also cause a change in their mental status. So doing a thorough pain screen is also important. The E stands for eyes, ears, or environment. So sensory deprivation can really, really contribute to delirium. Making sure patients have adequate hearing aids, glasses. If they are bed down, making sure at least they have some exposure to sunlight or getting people up and walking and out as much as possible really helps to minimize their delirium. Any low oxygen states that deprive the brain of oxygen can cause mental status changes. And these are, in general, medical emergencies, and kind of anchoring yourself to a diagnosis of a urinary tract infection, you might miss the mark on something really important. So, again, it's really important to do a thorough screen when somebody has a change in mental status. Not only urinary tract infection, but various infections can cause mental status. R could be for retention, whether it be urinary retention or fecal retention or constipation, can also cause some changes in mental status. Post-ictal, or after someone's had a seizure, they can be a little bit loopy. dehydration, whether it be undernutrition or underhydration, can cause mental status changes, and is something that you should kind of keep an eye out just in general. Metabolic causes like high or low blood sugar, sodium abnormalities kind of ties into the dehydration. And lastly, any head trauma, whether it be a subdural hematoma, but it could be a concussion, any sort of head trauma can cause changes in mental status. So here I have a laundry list of all of the things that could be causing a change in your patient's mental status besides just UTI. So all of these really should be evaluated before you initiate antibiotics. So we talked a lot about urinary colonization. I want to talk about respiratory colonization as well, as just because there's bacteria present in your respiratory tract, again, does not necessarily mean that there's an infection there. Viral infections often present very similar to bacterial infections, but some of the hallmark differences are the duration of symptoms, and viral infections also tend to have very profound rhinorrhea, so a lot of nose running. And if you happen to send a sputum culture, you very likely can just pick up oral pharyngeal colonization. We have a lot of bacteria that live in our mouth and throat, and getting a good sample of sputum from deep in somebody's chest where you think that there's an infection can be really challenging, especially in our elderly debilitated population, where they don't necessarily have the strength or reserve to be able to give a good cough. And a culture very often may represent their status. Also, a way to determine whether or not you have a good sample is looking at the gram stain to look for things like skin cells that may come off of, a patient's cheek, or whether there's white blood cells there that would be associated with infection and inflammation. And lastly, when we're looking at chest x-rays, you really have to correlate it to signs and symptoms of infection. So patients can have infiltrates on their chest x-ray for various non-infectious reasons, and improvement can also take a really long time, especially in our elderly patients. So looking for radiologic improvement is not really useful. There's no good test of cure after pneumonia besides just symptom improvement. So if a patient recently had a pneumonia and you look at a chest x-ray, seeing an infiltrate there doesn't necessarily mean that they have another pneumonia, but it really begs the question of whether or not it's worse or if it's just slow to improve. So if you are thinking about initiating antibiotic treatment, I just want to remind you of a few circumstances in which antibiotics are not indicated. So the vast majority of acute bronchitis and sinusitis does not warrant antibiotic therapy. It's almost always viral in nature. Also, if a patient has a positive sputum culture, but a clean chest x-ray, that is not pneumonia, that is positive sputum culture, is probably representative of oropharyngeal colonization.
Shira, I'm so sorry to interrupt. We are hearing a lot of coughing in the background, so if you joined after we muted the line, can you please just press *6 to mute your line? Thank you so much, and I'm sorry, Shira.
Next, if someone has a chest x-ray that looks abnormal, but if they're feeling better, we're going to call that healthy and not representative of any pathologic process. And lastly, if somebody has chest x-ray findings that are consistent with a non-infectious or viral process, that's where we really lean on our other tests, like our flu, our influenza test to diagnose somebody with maybe influenza pneumonia, or if somebody has a cough and fever that gets better and then worse, then only do we think about it being a bacterial super infection and then starting antibiotics later. The last circumstance where antibiotics should be considered is just if somebody has a moderate to severe COPD exacerbation, because although those aren't infectious in nature, antibiotics can help because they're usually part of the problem. But then again, those are patients in which you should probably be considering hospital admission anyway, so you don't necessarily need to initiate antibiotics before the patient gets to the hospital. I want to talk briefly about antibiotic treatment of chronic wounds because this is an area in which there is a lot of inappropriate antibiotic consumption for over really long courses. Wounds look gross. They just don't look pretty. And very often that can get misconstrued as they look infected. Healthy granulation tissue is a good thing. It doesn't look appealing. It looks gross, but when you're diagnosing a patient with a wound infection, you really need to see things like cellulitis, purulence. It needs to be an angry red. So just because it doesn't look great doesn't necessarily mean that antibiotics are going to help. Furthermore, when you culture these wounds, very likely you're just going to pick up colonization of the wound. The more antibiotics you give, the more you're just going to select for various things, and potentially if you give antibiotics, we very often select for fungus to grow on top. Those are all just colonization living on top of the wound and not necessarily indicative of any sort of infection going on inside the wound. So if there is a suspicion of a wound, in that case, think about getting more of a deeper and more telling culture than just a superficial swab. And lastly, if you do need to initiate antibiotic therapy for a wound infection, make sure you're doing your shortest course possible. It shouldn't really be more than 1 to 2 weeks if it's a soft tissue infection, and really only needs longer courses if the infection goes all the way down to the bone. So here we have a decision tree that helps us decide whether or not antibiotic therapy is appropriate for a wound. So you may sometimes be getting epidemiologic culture. So if this is an epidemiologic culture, do not treat it whatsoever. Just completely ignore the result. If it is a clinical culture, that's when you need to review what it is that it's growing and treat with the narrowest spectrum agent possible. But again, making sure that you're really only culturing when patients are truly showing signs and symptoms of infection. The last system I want to talk about that can commonly have colonization is C. diff or C. diff diarrhea. So there are a lot of different tests out there for C. diff that your facility may or may not be using. The two most common ones are the toxin assay, which lacks sensitivity. So the toxin is pretty labile at room temperature. If you collect a specimen and it's just sitting out there for a while, the toxin can break down, so you could have a false negative. And in those circumstances, very often we look to use a PCR-based technology, or some people just use the PCR up front. This test actually is overly sensitive and may sometimes cause some false positives because it's looking for the gene for C. diff toxin, or the ability for C. diff to produce toxin, not necessarily the toxin itself. And so patients who recently had C. diff but they're clinically cured are going to hold on to that C. diff for a little bit, or sometimes they could even develop chronic colonization with C. diff. But if they're not currently infected and currently having any infectious diarrhea, not only should you not be testing them, you should not be treating them as well. As C. diff rates are more and more important and reportable, we have kind of ventured into the realm of making sure that we exercise not only treatment stewardship, but also diagnostic stewardship, and really only testing the patients in whom we really think they have C. diff. So a single bout of diarrhea is not consistent with a patient having C. diff diarrhea. We encourage our nurses to not to collect a specimen unless the patient has had at least 3 loose bowel movements in 24 hours. Also, thinking about are there any other changes that can explain a patient to develop diarrhea? If it seems like they have had an acute change in their diet, an acute change in their medication, maybe if they, think about if there's anything going around, any sort of GI bug, are all reasons to consider why a patient may have had diarrhea before deciding whether or not you should test for C. diff. Because if you're picking up colonization, it could reflect your numbers poorly and also result in overtreatment of adaptation C. diff. So with that, I want to transfer to Shira, who's going to talk a little bit about some really great initiatives that we've had here in New England. So hopefully many of you are already having these discussions within your facilities about what is colonization versus infection and who actually should receive antibiotics, about who should be tested for infection in the presence or absence of actual signs and symptoms of infection. I hope that you are familiar with the term asymptomatic bacteriuria, and that you're familiar with the concept that altered mental status is not an indication necessarily for a urine culture. And some of you may have even participated in these past collaboratives where we have talked about these things and recommended interventions to improve care in this area. And for those of you that didn't participate and aren't having these conversations yet, I really want to tell you about past success that we've had in the area of use of antibiotics in long-term care residents with suspected UTI. And this is a collaborative that we implemented in the state of Massachusetts a few years ago. And it was an effort between some experts from academic medical centers like Tufts with Massachusetts Senior Care Association, QIN-QIO, the Massachusetts Department of Public Health, and the Massachusetts Coalition for the Prevention of Medical Errors. And in this initiative a few years ago, we embarked on the goal of improving the evaluation and treatment of urinary tract infections, decreasing treatment for asymptomatic bacteriuria. We wanted our facilities to use clinical quality improvement tools for decision support and to improve their communication with patients and their loved ones so that care could be safer, meaning not using antibiotics when they aren't indicated. So it's been a few years now, but we picked it up in 2012. And the first initiative lasted a year, and then it was so successful that we did it again in 2013 to 14. And the initiative involved in-person workshops and coaching calls and webinars, and lots of sharing and learning calls, and lots of printed tools and online support. During the in-person workshops, we had roundtable discussions. We had lectures given by experts in the field, and we rolled out this tool we call the ABCs of urinary tract infection. And we will put a link to all of these materials in the slides and email them out to you as well. And so the A was for assessment, and basing this on the existing guidelines and literature, we asked facilities to start using specific criteria for testing, and that patients or residents who didn't meet these criteria should not be tested. And we had separate criteria for residents without and residents with an indwelling catheter. And so this urea alone in a resident without a catheter is enough to send a urine culture. That is a symptom that's specifically referable to the urinary tract and can be associated with the urinary tract infection. But if it's just fever alone, then we actually require there to be some additional symptoms that are specifically referable to the urinary tract infection. And if there's no fever, we actually require two specific symptoms: urgency, frequency, suprapubic pain, gross hematuria, constant vertebral angle pain, and urinary incontinence. And note that all of those symptoms are specific to the urinary tract. The mental status alone is not specific enough. It becomes harder when the resident has an indwelling catheter, and this is a huge reason to remove those urinary catheters, because you can't properly assess somebody when they have one. And so if they have an indwelling catheter, you may not see dysuria. You're certainly not going to see frequency. In these cases,
oh, hi. Sorry.
Stop for a minute. Yep.
I'm just going to go ahead and remute all the lines, but first I just have to unmute them, so just bear with me one moment, okay?
Yep.
The leader has unmuted your line. The leader has muted your line. To unmute your line, press #6.
Okay, and so you can see that in those residents that do have indwelling catheters, we require only one of the symptoms below. But that is going to lead to a lot of excess testing. So again, getting those catheters out is key. And so going on with the AUDCs, B stands for bacteria, and that is really about properly evaluating that urinalysis and culture, but only ordering them if those criteria are met. So you want to collect a clean, avoided specimen if possible. That's an in and out catheter, ideally. If that resident has a chronic indwelling catheter, you need to change it. If you culture, pull that urine specimen through the catheter, it is going to be positive in 100% of cases of residents who've had a catheter in for 2 weeks. So you'd want to change that and send urine that came through a brand new catheter. You may want to do a CBC, a chemistry, if that resident has systemic signs and symptoms like lethargy or fever. And if they have a white count that's elevated on their CBC, you definitely do want to consider infection, urinary tract or otherwise, regardless of whether they have a fever. So you're going to have 3 relevant pieces in your urinalysis result, and that's your nitrites, your leukocyte esters, and pyuria. And so you're going, and we consider a white blood cell count in the urine of greater than 10 to be clinically significant. And then you're going to have your culture result, which will have a quantity associated with it. And we consider a clean patch specimen positive if it has greater than 10 to the 5th organisms in it, but less than or equal to 2 organisms. So once you have 3 organisms or more in your urine, you definitely have a contaminated specimen, and that's really not going to be a relevant result. If you have a catheterized specimen, either straight cath or a new fully catheter, then we consider it positive if the resident has greater than 10 to the 3rd organisms with greater than 1 organism. But these things here in the urinalysis and the culture that we consider positive are only positive if that person met the criteria in Section A. None of these things are relevant in the slightest if the person doesn't have the symptoms that we discussed in Section A. Now, the test may have been sent, despite the absence of the criteria in Section A. And then what we're asking you to do, and we know it's difficult, is to ignore these results. The C in the ABCs of urinary tract infection management stands for care plan. And that's where you take your information from A and B and you put it all together. So did that person meet the criteria for UTI symptoms and have the criteria for a positive urinalysis and culture? And then you're going to review the treatment with antibiotics, continue monitoring their vital signs, monitor their fluid intake, increase it if indicated to help them clear that urinary tract infection. But if they did not meet criteria A and B, you're going to look at that person for an alternate diagnosis. Okay, maybe they do have an elevated white count or a fever, but it's not a urinary tract infection, so let's see where the infection is. Or maybe they don't have an infection at all. Maybe they have altered mental status because elderly patients with dementia have waxing and waning mental status. So monitor them. Again, look at their fluid status, which is a huge reason for changes in mental status and in things like energy and appetite, and keep reevaluating them. If they develop the above criteria, A and B, and so you now think that they have a symptomatic UTI, at any point you can decide that they're eligible for therapy. Reevaluate, review with the provider and if they develop fever more than 100.5, which is what we would consider significant, if they have changes in vital signs, heart rate, respiratory rate, blood pressure, oxygen saturation, finger sticks, those are obviously all signs and symptoms that should raise concern and consideration for more in-depth evaluation. It's also really important to look at things like your advanced directives. And your residents should have advanced directives that address antibiotics, because antibiotics are not part of comfort measures and should not be used that way, particularly because of their impact on the broader community and their ecological impact and their global impact. And so you may have residents, and you should have residents, whose care plan specifies that they won't receive antibiotics even with a proven infection, and that this may be part of their end of life, of what contributes to their end of life. Medication allergies, of course, should be assessed if you're considering antibiotics, and then drug interactions, particularly warfarin or Coumadin, which is commonly used in the elderly population, may need to be taken into consideration when choosing an antibiotic. And here on the tool, we have some of the causes for mental status change as a reminder, which we've discussed. So in the collaborative, we provided all facilities with, I sort of squished the graphics together, but with these nice color posters that we encouraged to be posted on the walls in the facility work areas. These are education sheets for clinicians to make sure they're aware of the concept of asymptomatic bacteriuria, the myths and facts, the issue with antibiotics and resistance, and the risk of death associated with resistant bacteria. We also provided infographics and materials bringing forth this concept of a stoplight. When you think about testing and treating for asymptomatic bacteriuria, you sort of think of it as red, yellow, and green, where red are those residents who have no symptoms of UTI whatsoever. You shouldn't test and you shouldn't treat, so stop right there. The green are the residents with clear, specific symptoms of UTI, and those you would test, and if positive, you would treat. Whereas that yellow is really the tricky group. Those are the residents who might have weakness or delirium or fever without those specific symptoms referable to the urinary tract. And in those residents, you individualize care, you're mindful of the presence of asymptomatic bacteriuria, and you're not going to hastily prescribe antibiotics without having some more evidence, and you're going to look for other causes for whatever symptoms they are displaying. Also available on the website, and we're going to show you the link, resident/family brochures. So color documents that you can print and fold into a nice little brochure that you can provide to residents and their families on when do you need an antibiotic, and what the benefits and risks are associated with antibiotics, and then some specific a specific insert that we created to go in there that talks about urinary tract infections specifically. The bottom line is we encourage clinicians to use their best critical thinking, not to have knee-jerk reactions, and not to test and treat everyone out there who they previously might have tested for urinary tract infection. And the link is here, so it's on the Massachusetts Coalition for Prevention of Medical Errors website under initiatives, but here's the direct link. And so, in that year one of the initiative, we had 36 facilities participate. We actually had 17 submit data on how many urine cultures they sent, and how many residents met criteria, the ABC criteria, and we also had their C. diff rates. And so in that time period, there were 371,000 resident days And we compared that period with a baseline period before the initiative that included 246 resident days, just so you get a sense of the magnitude of this data. And then in the second year, we did the program again. We had 32 facilities participate at that time, some of whom were the same, actually. We had 25 facilities submit data, and 12 of them of those 25 were new, but 13 had actually participated in year one. I guess they liked it so much they returned for more. And we had 300,000 resident days again in that evaluation period. And so you can see that we had, in the baseline period, which is to the left of the vertical line, we had a high rate of urine culturing per 10,000 resident days. And then you can see that when the intervention began in year one, there was sort of an initial and sustained decrease in the number of urine cultures sent, adjusted by census. And then this graph shows you the baseline period, the period that we call collaborative 1, the period of time, the several months in between where we weren't doing anything, and then the period that we call collaborative 2, where 13 of our facilities, 12 of our facilities actually came back for a second year. And you can see that even for those that came back for a second year, they continue to see increasing success, as evidenced by decreasing rates of sending urine cultures on their residents. And then the bottom graph only shows those 13 facilities that were new in the second year, and they experienced success as well. So that was urine culture sent. Here's the rate of urinary tract infections diagnosed. Now, this isn't an infection control initiative. This is a stewardship initiative. So this doesn't reflect real urinary tract infections, which might be defined by some accepted criteria. This is just urinary tract infections diagnosed by their clinicians. And here you can see in the first collaborative year that we saw a decrease in the number of urinary tract infections diagnosed, or the rate adjusted for 10,000 resident days. And then in the second collaborative, for those that continued, again, we see continued success. When you look at collaborative 1 and collaborative 2, they were there for collaborative 1, but they solidified that understanding, is how I see it. In collaborative 2, I had even further success in decreasing the number of urinary tract infections diagnosed. And then the bottom graph there is the new facilities that participated only in the second collaborative, and they experienced success as well. We also saw some decreases in Clostridium difficile infection rate, and that, as we know, is associated with a combination of factors, infection control factors, and hygiene, but also antibiotic usage, because Clostridium difficile infection requires that double whammy of acquiring the organism and then getting an antibiotic to affect your baseline underlying flora and allow the C. diff to grow. And so in the first collaborative, we saw an incident ratio that was 0.55, and that was actually the one time period in which it was statistically significantly lower, but we did see incident rate ratios lower than 1, suggesting that perhaps a trend towards lower C. diff rates, both in the continuing facilities in the second collaborative and the new facilities in the second collaborative. But the numbers were quite small there, and it may have been difficult to see that difference statistically significantly. So again, here's the link at the top to directly find the collaborative tools, or you can search for the Massachusetts Coalition for the Prevention of Medical Errors, look under initiatives, and then evaluation and treatment of UTI in the elderly. You will also find on the Interact website, which many of you may be using, Care Path, and the Interact Care Path for symptoms of urinary tract infection align very well with the materials that are on the Coalition for Prevention of Medical Errors website. Interact also has a care path for acute mental status change that does not involve automatically sending a urine culture, and for change in behavior, which is a little bit different. That does not involve sending a urine culture. So I just want to make sure I acknowledge all the people that were involved in the successful initiative, which was supported by the CDC grant, and many of my colleagues at the Department of Public Health and in the coalition were extremely instrumental in the success of that program. And so we have a few minutes. I'm going to, am I passing the ball hopefully back to my
Sarah.
And we will have time. You can put your questions in chat, and we'll take questions over the phone if there's time. But I'll pass it on to QIN-QIO to close us out.
So that unmute your line. Please dial #6. And you can ask a question. Also, you can ask questions in chat. If you have a question asking for the PowerPoint slides, I did provide the link to access those on our website. We also had a request from Heather asking if we can email any colored posters that were referenced in the presentation. Is there an opportunity for us to provide those in the thank you email that we send out tomorrow?
Sure. I don't see why not.
Excellent.
I have a question. Can you hear me?
Yes.
Yes.
Can you hear me?
Yes, we can.
All right, so two questions. One question is two parts into it. How, dealing with physicians, do you have any good strategies when you have a physician in particular who really likes to order antibiotics? I deal with one physician who will put somebody on antibiotics one day, discontinue it the next day, then say it's obtaining some sort of a culture, and I'm really kind of looking for some good literature that I can kind of share with him that he would be thinking about.
Yeah, I mean, there's no, as a physician, I can say there's no one-size-fits-all approach. You want to involve your facility administration at the highest levels to make sure that you're requiring your physicians to obtain education in the area of antimicrobial stewardship, and there are so many resources out there now, including all of the webinars on these webinars, but also all of the webinars on the link that I just sent you for the UTI initiative, which we're geared towards both physicians and nurses and facility administrators. There are national guidelines, and they are very clear. There is an Infectious Disease Society of America national guideline on the management of patients with asymptomatic bacteriuria, and it's right there in black and white that this particular type of patient should not be treated with antibiotics. We hear a lot about psychiatrists who require a urine culture before they'll make adjustments to the medications that are being used to manage behavioral issues. That's a problem because that is not indicated in a patient whose only symptom is behavioral issues. So you do need to keep chipping away at that and utilize all the resources that we have been providing.
And one last thing that I'll add is, physicians want to do the right thing. Nobody goes into medicine because they want to misuse antibiotics or do harm to anybody. So really empowering and reminding our physicians that they really are here to do what's best for our patients. If a patient has a C. diff, an instance of C. diff, we found it useful to feed that information back to the physician and say, hey, I noticed that Mr. Jones has C. diff now. He just finished a course of Cipro for a UTI. Do you think this is avoidable? And really force them to reconcile with their own behavior, and that can help kind of, guide them to really reevaluating their practices.
All right, thank you.
There's a question here also about what do we do about nurse practitioners or doctors who are placing patients on prophylaxis. Prophylaxis is not recommended in any national guideline. In our experience, it doesn't work. It may slow down the frequency of urinary tract infections initially until that person is so heavily colonized with highly resistant organisms that those start to break through, and then those are harder to treat. So you're not going to do the patient any service by using prophylaxis for recurrent UTIs. And we know that those recurrent UTIs are often not UTIs. Those are recurrent positive urine cultures, and as we've seen, since 50 to 80% of elderly females have a positive urine culture on any given Wednesday without having a urinary tract infection, a lot of these people are labeled as recurrent urinary tract infections when in fact they're just normal. So that's definitely another thing that you want to be chipping away at with your providers, involving your highest level of administration and making sure that they are availing themselves of these educational opportunities that we have created here. There's a question, this is one of our most common questions. If a resident is colonized with any MDRO, should isolation precautions be instituted? So I think this is a really, really key point, though. What we're talking about here, we've talked about isolation, colonization versus infection from the antimicrobial stewardship standpoint. And when we talk about colonization versus infection from antimicrobial stewardship standpoint, we mean that those are people that should not be treated. When we talk about colonization versus infection, on the infection control side, it is important to realize that even colonized patients can transmit that organism, but probably not with the same frequency or to the same degree as an infected person where that infection is of a type that's very secretional, right? So an infected wound that's full of MRSA and that's where pus is dripping out of it is certainly going to transmit a lot of bacteria to the environment, more so probably than a colonized one. There are no hard and fast rules about isolation precautions when it comes to multi-drug-resistant organisms, with the exception of the most resistant gram-negatives, the CREs. And so if you take a listen or look at the prior webinars that we've done on January 16th and April 3rd, we talked quite a bit about the need to develop your own internal policies for isolation precautions for colonized and infected patients, and there aren't, and the CDC and Department of Public Health guidelines are not really that prescriptive about it.
So there's another question asking about whether or not this can be applied in various settings, and we agree that antimicrobial stewardship really needs to be tackled across the spectrum of healthcare, in acute care, in long-term care, in outpatient care, and there are a lot of initiatives going on across the care continuum, because it really does need to be a collaborative effort. If you guys, if in a long-term care facility, you hold off on giving antibiotics, but then send someone to the ED, and then there they give someone antibiotics, it's just kind of not useful. So there are a lot of initiatives going on across various levels to really improve antibiotic prescribing.
Yeah, there's really nothing that we said today about colonization versus infection that would be different in a hospital setting. And then the last question, what about antibiotics used indefinitely due to chronic symptoms or recurring symptoms? And the answer is there should be almost no antibiotics that are used indefinitely due to chronic symptoms or recurrent symptoms. I think that the only exceptions to that would be some kind of infected hardware where the hardware can't be removed.
Right. So
sometimes we do have patients that may warrant chronic suppressive antibiotics, but this is a very narrow number of patients, and that may be because they had either, I'm talking about cholestatic joint infections that stayed in, and they couldn't remove the hardware, patients that had urological symptoms and went into sepsis and have stents in place and they need to be removed, but that's for a short period of time. So it's a niche of patients that maybe might require antibiotics for a longer period than what we have been talking about. But I would encourage to make sure that those patients are being actually evaluated by an infectious disease physician, because it's really a specialty once you get to that point when you're having someone on chronic antibiotics for more than what guidelines say. So that's probably why, and reevaluate, always try to figure out if it was really recurrent or it was really chronic. Even if you see that an ID physician sends a patient to a long-term care facility on chronic antibiotics, always question and try to reevaluate the patient just to make sure that they're not on unnecessary antibiotics.
And one last thing that I'll add to that is there are a lot of issues across our healthcare system with medication reconciliation. And the information may not be accurate or up to date when you receive it about what is the anticipated stop date or whether the patient even was on or continues to continue to be on antibiotics. So at all of your transfers of care, it's a good opportunity to reevaluate what antibiotics the patient is on or needs. All right, with that, here we have our upcoming series. Nayara, are you still on?
This is Sarah. Can you close it out? Hello? 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 Hi, I'm sorry. Can you hear me?
Yes.
Okay, I actually have one question. My name is Rachel. I'm from Elliott. We get a lot of post-surgical residents here. And, speaking back on the prophylactic antibiotics, a lot of them come with antibiotics because of the surgical date. Yes, there's a stop date. But sometimes, our newly, dialysis patients, they're on, usually antibiotics, and that's given every time they go to dialysis. How does that play into C. diff and UTIs? I mean, UTIs not so much for dialysis patients, but C. diff maybe.
Yeah, so a patient who only gets antibiotics with dialysis is pretty much the equivalent of a patient that's on antibiotics all the time. The fact that their kidneys don't work anymore just means that they're holding on to the antibiotic longer and can get infrequent doses, only when they get hemodialysis. So I would treat those patients just as any other patient that would get an antibiotic 3 times a day in terms of reevaluating whether they really need that long course and whether it's appropriate.
Right, but that's not really up to us. That's more on the doctor at the dialysis center, and we can only recommend what we recommend. I don't know their protocol.
Right. Are we talking about patients that are on dialysis on an antibiotic for what they think is an infection? Urinary tract?
They usually do it for hemodialysis patients. They give them, either IV Vanco or ceftriaxone every time they go there, just to minimize, any, I guess.
For indefinitely?
Yeah.
That is bad. Yes. That is not good. I've never heard about this before. I don't know if this is related to a particularly dialysis center. But having someone on Vanco or ceftriaxone indefinitely without really having a diagnosis of an infection or chronic infection, it doesn't seem to add up.
All right, maybe I'm just thinking of a specific patient then.
Okay.
But okay.
Anyone else have questions?
This is Sarah with the QIN-QIO, and we're running out of time, so I did want to take a moment to thank you, Shira, Kira, Gabriela, and Melissa. As you can see on this screen, we have upcoming webinars for the series. Webinars take place monthly through September, so don't forget to mark your calendars and check out the New England QIN-QIO's website for more information. I did include a link to the website in chat. Also, if you have been actively engaged in the New England QIN-QIO's Learning Collaborative and did not yet receive your quality commitment badge, please contact your QIN-QIO state nursing home lead. And if you have received your badge, make sure you're sharing your commitment to quality. Take a photo of your badge displaying it in your front entrance. We also encourage you to also include members of your team in the photo. Post it to social media using the hashtag WeCommitToQuality and tag the New England QIN-QIO on Facebook, Twitter, or LinkedIn. Our social media handles are listed here on this slide. And a big thank you to the team at Mary Immaculate in Lawrence, Massachusetts for their commitment to quality. They posted their badge in their front entrance, posted and tagged the New England QIN-QIO on Facebook. Make sure you take a photo and share with us on Facebook, Twitter, or LinkedIn so that we can celebrate your commitment as well. You may be highlighted in future QIN-QIO webinars or newsletters. In addition to our appreciation for your commitment to quality, later this year we will be announcing the New England Nursing Home Quality Care Collaborative Award winners. Nursing homes will receive a ribbon, either blue or gold, to display along with your commitment badge to acknowledge your accomplishments during the collaborative. The awards program winners will be determined by the criteria that are listed here on this slide. And it's not too late to secure an award. The next step towards achieving your collaborative quality award is to submit a best practice or success story. The New England QIN-QIO continues to spread best practices throughout nursing homes in New England, and we're asking you to share those successes. I have included a link for more information on the awards program, and this is also where you will submit your success story. The link is provided in chat. And as always, if you have any questions, please reach out to your state nursing home lead. We're happy to connect you with today's speakers. If you have any additional questions that you weren't able to ask today. And thank you all for joining. Have a great rest of your day.